fractures of proximal humerus are still an unsolved problem. Plate fixation always provides a better stability. We have designed a special plate called single-tine proximal humerus T plate for such fractures. It is a 3.5 mm fixed angle plate. Glenohumeral joint has more motion than any other joint in the body. So a balance between the soft tissues and osseous tissues is very important to obtain optimum results. Fractures are basically classified by niche classification, which is followed globally. Coming to materials and methods, our study was a combined retrospective and prospective study from July 2004 to December 2008. Total number of patients were 35, 10 were retrospective and 25 prospective. Radiographic evaluation was by true AP and axillary lateral view. And also a well-view axillary view was done in patients where abduction was not possible. The preoperative assessment of the patients included a thorough neurovascular evaluation, plus tracings of all the fracture fragments were done preoperatively, and neuro studies like EMG and NCV were done as a routine in all patients. The instruments and implants were basic ortho instruments which were used. The plate which we used was a single-tine proximal humerus plate. This is the plate. It is a 316L stainless steel plate which is pre-contoured with a central tine. This is a central tine. The dimensions are 25 mm proximal it is in the thickness, and it is available in 2x5 by 2x6 hole plate which accommodates 3.5 mm screws. The surgical technique, we used general anesthesia in all patients, and the classical incision was described by Keshan, a deltopectoral incision. Coming to step 1, which is a deltopectoral incision which is taken. Then the exposure of the deltopectoral interval with the cephalic vein. Exposure of the fracture fragments was done, and retraction of the deltoid laterally and pectoralis major medially. Then the fracture fragments were anatomically reduced, and biceps long tendon at times can be exposed to check the rotation of the fragments. The fracture reduction was maintained by a single-tine T plate placed laterally under image control. The plate is basically placed with the help of a jig which is designed by us, and care should be taken to avoid high positioning of the plate and varus position of the head. This is a Siam picture showing the fixed angle plate being applied. This is a post-operative regimen which we use chest arm strapping for 2 weeks, followed by a shoulder sling. The sutures were removed at the end of 2 weeks. Then gentle pendulum exercises were started at the end of 2 weeks, and gentle passive exercises after 4 weeks. Check X-rays were taken at 4 weeks, and active exercises after 8 to 10 weeks. The post-operative evaluation was done monthly for up to 3 months, then every 2 months for 9 months, and check X-rays were taken to know the position of the implant and fracture healing, and patients were evaluated according to needs clinical evaluation criteria. These were the observations. We had around 31% of three-part fractures, and the patient's age group included from 24 to 77. Basically, the patients belong to between the age group of 40 to 60 years, of which 54% were males, and right hand dominance. The mode of injury was RTA and fall moreover. RTA is road traffic accident, while in others patient like it was in one patient it was seizures, and the other patient it was electric shock. Associated neurovascular injuries were seen in around 3 patients. 2 patients had nerve injuries, and which is axillary nerve neuropraxia, which recovered later on in matter of 8 weeks, and 1 patient had vascular thrombosis of the axillary artery, which he developed good collateral circulation, so nothing was done. Bone grafting was used in all patients, all type of fractures as a routine. Coming to results, the patients were evaluated, were followed up for an average of 22.75 months, and according to needs evaluation criteria, we had 91.44% excellent to satisfactory results, and only 5.71% unsatisfactory results. There were no failures in our cases, and in a matter of 16 weeks average, the fractures united radiologically. Then the grading was done. Then coming to post-operative complications, 2 patients had shoulder stiffness, which they recovered slowly, and 1 patient had some subclinical infection. AVN was seen in 1 patient. Coming to variety of cases, this is a 2-part fracture with vertical shear. He was fixed with the same device and clinically showing excellent results. Coming to 3-part fracture, this lady had a 3-part fracture fixed with same plate and excellent results. 4-part fracture. Then coming to special cases like anterior fracture dislocation of the proximal humerus, which was also fixed with this plate. This is a shoot-through X-ray, and the CT scan confirming with a 3D reconstruction. This is a post-op X-rays imaged, and at the end of 14 months, this was the clinical outcome. This was a 3-part fracture which was fixed with a nail, came to us and again operated with excellent results. This is a head-splitting fracture, which is very uncommon but with good results. Coming to complications, we had 1 complication post-operatively, which the patient developed AVN, and but he has no pain post-operatively and the implants were removed. Coming to discussion, ORIF, there are 2 options for treatment of proximal humerus, ORIF and arthroplasty. ORIF has advantage of bilateral fixation and no loosening. Then disadvantages, technically demanding AVN of humeral head and maintenance of reduction is a problem. These are the problems with ORIF. Current techniques of ORIF, there are percutaneous pins, sutures, wires, as was told in previous lecture. Then there are different plates which have gone modification for fixation. Initially there was AOT plate, then a plate by Sir and Savo, Hinterman, lock plates are recent things. Plates have undergone modification because there is a toggle between the screws and the plate which pull out, and there is loosening and leads to varus malformation. And the various literature supporting ORIF include, this was from Amsterdam, which showed 87% had good results. Arthroplasty is easier but not dependent on bone healing, but the disadvantages are implant loosening, revision surgery, and dislocations. According to Kralinger, only 41% patients had were able to flex beyond 90 degrees, so it's not a good option. Then latest is reverse shoulder arthroplasty. Even these patients, only 97% had 97 degrees flexion was there. Then outcome of results, we had 91.44% good results as compared to the literature, which showed 74 in Bipavolian Christiansen. Comparison with other modalities like transosseous suture fixation, 78% patients had good results. Then our technique, it is a single-time proximal humerus T-plate, which is indigenous and cheap, provides significant stronger fixation and maintains fracture reduction. Conclusion, deltovertebral approach is ideal, accurate ORIF, stable fixation, and stable and vigorous physiotherapy is important for to achieve optimal results. And primary bone grafting helps in fracture healing. Thank you.